So, a 32-year-old para 3 plus 0 gravida 4 at 34 weeks gestation with 3 living children presents with 2 hours history of sudden onset of vaginal bleeding. Now, this bleeding is characterized, it's dark red in color, it's moderate in amount, and there is no any associated history of trauma. She also reports of severe lower abdominal pain, okay, with reduced fetal movement since the bleeding started. There is no any history of drainage of liquor, and there is no history of trauma, there is no history of fall, and there is no history of prior sexual intercourse before the onset of the bleeding. She is also on antihypertensive since 26 weeks of gestation. She is currently on a maternal. What do you think that we are dealing with here? Hello and welcome back. My name is Joseph Tsuma, always your favorite doctor. And of course, when you see me here, you know it is Matters Health. I'm here to bring you trusted health information wherever you are. You can follow me for simple, updated, practical, and reliable medical insight that will be able to keep you and your family healthy. You can also subscribe to my YouTube channel at Doctor on Wheels. You can also follow me on TikTok at Dr. Itsuma. So today I want us to discuss placenta abruption. So what is placenta abruption? But before we dive into today's topic, I want us to listen to some words of wisdom from the book of Micah, chapter 6, verse 8. And the Bible says, "He has told you, O man, what is good, and what does the Lord require of you? But to do justice, to love kindness, and to walk humbly with your God." And that is all that God requires from us, that we should walk humbly before Him, we should love kindness, and we should act justly. Okay? Among the many things that we can do, a lot of charitable work and a lot of things that we can do, this is among the things that God requires us to do. So let us dive into today's topic. So what is placenta abruption? So placenta abruption is the separation of a normally implanted placenta, okay? And it occurs between 20 weeks and before delivery. So before 20 weeks, that one is a miscarriage. And then, so under normal circumstances, separation of the placenta from the placental bed, okay, from the uterus, is supposed to take place after delivery. So if you have it separating between 20 weeks and before delivery, that one will be termed as placenta abruption. Now, it is among the obstetric emergencies, and it is one of the major causes of antepartum hemorrhage. Now, we have different types of placenta abruption. So we have the revealed placenta abruption, which is characterized by visible bleeding through the vagina. And then we have the concealed placenta abruption, which is characterized by trapped blood, okay, between the uterus and the placental bed. Okay, now the concealed one is the most dangerous one because it means then you don't see any kind of bleeding, and therefore it can easily lead to late diagnosis. And of course, with late diagnosis, it means then you end up with a lot of complications like maternal, hypothalamic shock, fetal distress, and you can even lose the mother and the baby. And then sometimes you can have both of them occurring at the same time, what we call mixed placenta abruption, where you have both concealed and revealed. Okay, now with that, it's still dangerous because then you're not able to fully quantify the amount of bleeding because part of it is concealed at the placental bed. Now, what are the risk factors? Who are the people who are at risk of developing placenta abruption? So number one are those mothers who are hypertensive during pregnancy. So you can either have chronic hypertension, okay, or mothers who are preeclamptic, okay, or who have preeclampsia. Number two is history of trauma. Now, the trauma can be any kind of blunt trauma to the abdomen, okay, which can be either as a result of an accident or even domestic violence, okay, during pregnancy. A mother who has been beaten during pregnancy. And then the other thing that can cause placenta abruption or increases the chances of placenta abruption is what we call sudden uterine decompression. So sudden uterine decompression is when you suddenly reduce the pressure in the uterus. And this happens especially when you rupture membranes, okay, in a patient who has polyhydramnia. So they had too much amount of amniotic fluid, or a mother who has more than one pregnancy. Okay, so after delivery of the first baby, there is sudden decrease in terms of the pressure. Okay, in the uterus, and therefore it can actually cause separation of the placenta from the uterus before even the delivery of the second twin. Now, the other risk factor is smoking or use of cocaine or even drug abuse. Okay, and then advanced maternal age. So basically, if you've been listening to my videos, advanced maternal age has been a risk factor in almost major obstetric conditions, okay? Preeclampsia, placenta previa, antepartum hemorrhage, postpartum hemorrhage, and now here, placenta abruption. Or mothers who have who have had multiparity, so who have given birth to very many children. Okay. Now, another risk factor is history of previous placenta abruption. So, if you have had previous placenta abruption, there is an increased chance of developing placenta abruption. And then the other risk factor is when you have a short umbilical cord. So, if the umbilical cord for the baby is very short, it means then it can easily pull and detach. And then history of thrombophilias and disorders in clotting, okay, that one also increases the chances of placenta abruption. And then malpresentation, where the doctor end up doing what we call external cephalic version, okay, or what we call uterine manipulation to try and bring that baby to present with the head. Okay, so that procedure can actually increase the chances of placenta abruption. Now, how do patients present? So, number one, they will present with painful vaginal bleeding. The bleeding will be bright red, and this will be associated with abdominal pain and uterine tenderness. When you try to examine the abdomen, there will be a lot of tenderness, and the uterus will be tense and it will be woody hard. Okay, and then this vaginal bleeding can be variable, so it means then it depends on the type of placenta abruption that you're having. You can either have the concealed one. So with the concealed one, it means the bleeding will not be present. Okay, and here the patient can only present with signs of shock. Okay, where there will be hypotension, there will be increased heart rate, there will be diaphoretic, okay, and there will be cold extremities and all that. And then for the revealed one, basically there will be frank bleeding that you can see. And then the patient can also present with fetal distress, okay, where they tell you that the baby is not playing so well in the tummy, or there is reduced fetal movement, or they are not feeling the baby kicking. And when you do examination, you have signs of fetal distress, like either bradycardia, fetal bradycardia, or fetal tachycardia. Okay, and if they present very late, sometimes when you do the examination, you might actually not feel the fetal heart rate completely, which means basically you'll end up with intrauterine fetal death. Now, take that as well, this patient might present with signs of shock, okay, which might not be proportionate, especially if the bleeding is concealed. Now, we can also classify placenta abruption depending on the amount of bleeding. So you can have mild, moderate, and severe, or grade 1, grade 2, and grade 3. So mild is grade 1 where you have slight bleeding and there is no any signs of distress, and the fetal heart rate is still present and it's regular. And then moderate is grade 2 where you have moderate bleeding, okay, and this is associated with uterine tenderness or uterine pain, okay, abdominal pain, and then you have abnormal fetal heart rate. So you can either have bradycardia or fetal tachycardia. And then the severe, which is grade 3, is characterized by severe bleeding and some signs of shock or signs of disseminated intravascular coagulopathy and signs of fetal death where you do not feel the fetal heart rate completely. Now, let's look at the complications of placenta abruption. So we'll be looking at them in maternal complications and fetal complications. So for the maternal complications is number 1, hemorrhage, okay? Now this hemorrhage, when not well managed, it can lead to disseminated intravascular coagulopathy, and now with hemorrhage and hypovolemia and then shock, it can actually lead to renal failure, and patients who have had antepartum hemorrhage, okay, are at an increased risk of developing postpartum hemorrhage. So that one can actually as well be a complication. And then you have the covuleus uterus, where bleeding, okay, is basically blood starts to seep into the muscles of the uterus, to the myometrium, okay, and also the last of the complications is when you have bleeding that leads to shock, to that disseminated intravascular coagulopathy, renal failure, and you end up losing this mother, and then you get a maternal death. And then for the fetal complications include number 1 is prematurity. So you end up giving birth to a baby that is premature. You can end up with intrauterine growth restriction or retardation, and then signs of fetal distress, that is hypoxia, abnormal fetal heart rate, that is bradycardia, tachycardia, and if not, the patient presents very late, you might end up with intrauterine death. And if you end up delivering this baby, okay, because of prematurity or because of fetal distress, okay, you might actually end up with neonatal death as well. So you gave birth to, the baby was born breathing, but then because of the complications that came from placenta abruption, you end up losing that baby. How do you make diagnosis? So a good history and a good physical examination. You need to be able to look at the risk factors and be able to have high index of suspicion that you might be dealing with placenta abruption. Now, after you've done your good history and physical examination, you also need to do some tests. And a good test that you can do to be able to make to confirm this diagnosis is an ultrasound. Now, the ultrasound will be able to reveal a retroplacental clot, okay? But of note is that the ultrasound has low sensitivity, so you need to be able to have a very high index of suspicion. Now, the other test that you can do, especially for concealed, and this patient just comes in with signs of shock, you need to do a complete blood count to be able to rule out signs of infection, but also signs of anemia. Now, if you find anemia, you need to do urgent blood grouping and cross-matching, okay, so that you're going to transfuse and basically help with correction of the hemodynamic status of this patient. And also, because coagulopathies are also among the causes of placenta abruption, you need to do also coagulation profile. And then the other test that you can do that will be able to help, especially if the mother is rhesus, you need to look at the rhesus factor, okay? Because if the mother is rhesus negative and the mother was carrying a rhesus positive baby, it means the mother can get sensitized and they might not be able to give birth from a rhesus positive father again. Now, how do you manage? So number 1, you need to stabilize these mothers. So especially for the ones that are coming with concealed, they might come in with signs of shock. So you need to ensure the airway is okay, the breathing and circulation. You need to give IV fluids to be able to correct the hemodynamic status of these patients. And if they have lost a lot of blood, you need to do transfusion. You need to monitor their vitals so closely, and you also need to monitor the urine output. We talked about one of the complications being renal failure. And then for if you find any signs of coagulopathy, you need to correct that. Okay. Now, for mild and stable mothers, okay, they can actually be managed conservatively. Okay, so if the fetal heart rate is okay and there is no signs of shock, okay, you need to give them some bed rest and you manage them conservatively, ensure that they are hemodynamically stable, and then you can give them steroids, okay, for lung maturity for the baby. And then for severe cases, okay, where there is the mother is hemodynamically unstable, there is compromise, okay, to the baby, okay, so there is fetal distress, you need to do immediate delivery. Now, delivery is dependent on the status of the mother, but also the status of the baby. If you still have a good fetal heart rate, okay, you need to deliver this mother via cesarean section urgently so that you're able to save both the mother and the baby. Now, if there is no fetal heart rate, sometimes you can do induction of labor to be able to deliver vaginally and avoid those complications associated with cesarean section. Now, how do you prevent? Number one is you need to control maternal hypertension. So, manage maternal hypertension with accuracy. Okay. Now, for mothers who are basically are smoking, there is need for counseling for them to be able to cease. Okay. Avoid smoking and drug abuse during pregnancy, and then you need to monitor women with previous placenta abruption. Okay, so you need to monitor them very closely. There are what we call high-risk mothers that needs to be monitored so closely. And then you need to use seat belts, especially if you get into the matatu and you're using a matatu, you need to use seat belt because of reduction of accidents. Now, if you have found this lecture very helpful, please consider subscribing to my YouTube channel. You can also comment and share this video, and I will really, really appreciate. Now, until next time, God bless.